Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
I'm Dr. Ira Nash. Welcome to Well Said. Today, we'll be discussing ethical issues that arise in the medical setting. We talked about medical ethics about a year ago in the context of rationing care at the height of the COVID pandemic, and in determining what sort of allocation algorithms should be used to distribute vaccines, which you might recall were in very short supply at the time. With the pandemic fading, we thought it was a good time to revisit some of these issues and take stock of how the pandemic has affected the whole field of medical ethics. My guest is my colleague, Dr. Nicholas Mercado. Dr. Mercado is the Senior Medical Ethicist in the Division of Medical Ethics at Northwell and an Assistant Professor at the Zucker School of Medicine, and I'm delighted that he's on our show today. Dr. Mercado, welcome to Well Said.
Thank you for having me.
How have you been holding up during what has been an extraordinary time for all of us, but which I guess may have been even more extraordinary for a guy in your line of work?
I can say that I have been well during these times. Thank goodness my family as well. I can't say I'm blessed in this regard. I can say that with a full heart. And given everything that has happened over the last 2 years, wow, it's been 2 years now. Yeah. It has been quite a roller coaster. It has been quite challenging emotionally, professionally, but overall, I would say that I am very blessed to be where I am today.
Glad to hear that. So let's dive right in here. I'm sure many of our listeners may have heard of ethics in the academic sense, but I suspect it's much less appreciated how the principles of ethics are applied every day in healthcare. I have two questions to get us started. So first is, how would you define medical ethics? Give our listeners an introduction to what that actually means on a day-to-day basis in terms of the work you do in a hospital setting.
The way I view medical ethics, and this is something that I used to believe when I first doing this work, is trying to figure out what is the difference between a right action and a wrong action. And over time, I have come to appreciate that that is not necessarily the case, because if there were a right or a wrong answer, I wouldn't really conceive that to be an ethical issue or an ethical dilemma. So the way that I always look at medical ethics, and the way that it has been part of my life for about 6 years now, is medical ethics is trying to figure out which are the best decisions to make when in a healthcare setting, when there really is no quote-unquote good or bad answer or a right or wrong answer.
Give us a concrete example or two of what that might look like in the real world.
Absolutely. So a lot of the topics that we tackle in the ethics consultation service have, I'm sure a lot of people can recall or think about end-of-life issues. So issues surrounding withdrawing or stopping or withholding, not starting life support. What about when we have to deal with issues where there's discord between multiple family members when they don't really know what the patient would want? How do we deal with issues of allocating scarce resources? How do we try and mediate dilemmas between interprofessional teams such as physicians or nurse practitioners or physician's assistants? And I think on a day-to-day basis, a lot of what we do is try to address a phenomenon called moral injury, where maybe there is nothing that is quite right about the situation, meaning that there's no right answer, there's nothing that is going to suggest that a right answer is going to come anytime soon, but we try and alleviate the distress that comes with a challenge in healthcare. And this moral injury can happen to our colleagues in the health profession, and it can certainly happen to patients, friends, and families where, again, they're struggling with a decision that doesn't have a right answer. And that is what I do, that is what my team does in the hospitals, try and help the situation utilizing the principles that you had mentioned earlier.
So I think that's a very nice framework to continue our conversation. Lord knows these are not easy conversations that you're having with patients or with patients' families and the decisions that caregivers have to make. You approach this with kind of a framework of trying to balance certain principles. And I wonder if you could speak to what those principles are or the framework for the decisions that you help families and caregivers make.
There are several ways that you can approach any ethical dilemma in a healthcare setting. There is what we call the virtue-based framework, where the provider or the clinician is judged based on how they incorporated their own individual character in their decision-making. There is a duty-based framework where we can examine how a clinician or a caregiver, in any sense of the word, utilizes their understanding of what are they supposed to do. So we have virtue, which is character, and we have duty, which is what you do. But one of the frameworks that is most widely used and is widely used in our division of medical ethics and our ethics consultation service is that of principlism. And principlism is essentially figuring out how do we analyze any specific situation using 4 essential ethical principles. So the principles are as follows. The first principle that I'm sure a lot of people are familiar with, maybe not in this specific sense, is respect for the autonomous person. And that means that a person is able to make decisions with regards to their health care.
And that decision may be something that the caregiver or the rest of the family thinks is a bad idea, but we still respect the ability of the person to make decisions for him or herself.
Absolutely.
Okay.
And that means that the individual who is of sound mind, or we sometimes say competent or with capacity, makes a decision about their health care, and that decision should be honored, provided no one else is, I guess, impacted or hurt once the decision is made. So the respect for the autonomous person has to do with dignity, being able to maintain your own what we call bodily integrity, meaning alterations to your body should not happen without your consent, provided it's not an emergency. There are other ways to analyze that situation.
Okay, so number 1 is autonomy.
Correct. The second principle, actually the second and third principle, are kind of 2 sides of the same coin, where we have beneficence, meaning to do good by the patient, and that's wholeheartedly held by the caregiver, by the provider who is treating that person. And non-maleficence or non-malfeasance, both are used interchangeably, which means to either mitigate or refrain from harm when possible. And those are 2 sides of the same coin, beneficence and non-maleficence, to do good and to do no harm. Okay. And the reason why these principles are sort of separate is because it's generally understood that any amount of treatment or some treatment is going to involve some degree of harm, whether it be a side effect, whether it comes with some sort of extra issue that comes along with it. And I think the bottom line is we have to make sure that the benefits, the beneficence, the good of that care is going to outweigh the harms, the maleficence of that care. Then it's good.
Yeah, so just like you might have to do an operation and you're going to have a period of pain and recovery after the operation, but it serves a greater good in terms of the utility of the surgery, something like that?
Yes, that's exactly right. We have to analyze any care that we provide against a risk and benefit. And if, again, the benefits outweigh the risks, then it is important to offer that treatment. But at the same token, if the risks far outweigh the benefits, then it must be considered that that treatment is just not going to be offered to that person. And that's where sometimes we can have an ethical dilemma when you might have an individual who is willing to accept a risk that is somewhere in the 90%, 95% morbidity, mortality kind of range, but the clinician may feel reserved or reluctant to offer said treatment. So that's where an ethical dilemma can certainly appear as well.
Okay, so we have autonomy, beneficence, non-malfeasance, and the last one?
And the last principle that we go by is that of justice. And justice is in the medical ethics world or in the bioethics world is sometimes referred to as distributive justice, which is definitely more economic. That has a lot to do with the distribution of resources, but we also look at the social justice, which means looking at the social determinants of health, respect for people who are vulnerable populations, such as people with mental illness or developmental delay, people who don't have an advocate, such as the unbefriended person. They don't have any friends or family. And when we look at a justice-based framework, we also look at how care for an individual person might also have implications for society in general. And that's a very difficult analysis to make, because how can I say that treating this one person in this bed is going to have implications on a wider scale? But that's a discussion that normally has to be had in some regards. And I think as we kind of look back at the COVID-19 pandemic, we did see a lot of justice implications in the decisions we were making.
Well, that's the scarce resource problem, right?
Exactly.
That you have 1,000 people who need to be vaccinated and you have 100 vaccines. How do you figure out which 100 people get the vaccine?
Exactly.
Yeah. So this is a really interesting framework. Is this something relatively new, or is this sort of an application of thousands of years of philosophical thought to the modern medical setting?
The virtue-based framework and duty-based framework that I mentioned before, sort of glossed over, those frameworks are relatively old. They can be dated back several centuries, if not millennia. But the framework that I had shared before, the principlism framework, is actually relatively recent, within the last 50 years or so. And that is because a lot happened throughout history that required considerations of individuals, and not just, what the powers that be, what the researcher, what the scientist, what the doctor felt was best. And so when I talk about principlism, I'm really talking about a very modern framework of bioethics and medical ethics. And it has a lot to do with what was done throughout history, including Nazi Germany, including the Tuskegee syphilis study in the 1930s all the way to the early 1970s, and including many other types of studies like the eugenics experiments that actually happened right here in Long Island. So there are a lot of historical context that led to this modern framework of bioethics, which again has a lot to do with respect for the autonomous person, or respect for persons in general, and a clinician's duty to beneficence and non-malfeasance.
And how much of this change in thinking, or the evolution of medical ethics, is an outgrowth of, I'll say, the scientific advance of medicine itself, in a world where we don't have the technology to save desperately ill people or keep people alive after some major trauma or something like that, then these questions would never even arise. Is our own improvement in medical technology and medical knowledge having an impact on the field of medical ethics?
I definitely think that is a fair analysis of the situation. To kind of give a quick example, one aspect that I think we sometimes take for granted now versus several decades back is hemodialysis. Hemodialysis for people with end-stage kidney disease was quite a scarce resource
Yes.
at its very inception. And as the machines became more plentiful, as our techniques have gotten better, how we manage the side effects, and of course, as organ transplantation has gotten more widely used, there are more programs being set up, we have to alter our view on how to utilize that technology, how to utilize those techniques. So if something is not available, then there really can't be an ethical analysis of the situation. It's just simply not available. But I think what you're touching on a little bit, Ira, has a lot to do with justice as well, because there are several countries, third world or what we call lower middle income countries, that the ethics there is remarkably different because of the availability or inaccessibility of resources in the area. So we have to really take into account the contextual factors before we jump into an ethics discussion. What are the resources of the area? And can we say that ethics in the United States, or even ethics in New York, or even ethics on Long Island, is the same as any other place in the world? And I think we, again, have to kind of look at those differences before we jump into any sort of ethical discussion.
I want to get your reaction to maybe another aspect of that, which is
Sure.
that it's not just the presence or absence of resources and therefore their relative scarcity in a particular situation, but I imagine there are huge cultural differences in how individuals approach similar problems. So I'm thinking, for example, I think it's been well described that in, for instance, Scandinavian countries, it's much less common to offer the kinds of treatments that we routinely offer to people of advanced age. Because in those countries, it's just not as, I don't even know what the right word is. The expectation is different about what sorts of treatments are appropriate for people in their 80s or 90s or whatever it is. Am I getting that straight?
You're absolutely getting that straight. I think that there is a huge cultural framework that we also have to account for, as you said, not just the presence or the scarcity or abundance of resources. It's really about what are the surrounding laws and policies, what's the culture, what is the, I guess, if you really want to call it that, the dominant religion of that specific area. Are there subcultures within that area? Those all play a role when we consider the ethics of a situation. And when it comes to rationing or resource allocation, I feel that sometimes, particularly in the United States, that we sometimes get pretty heavy-handed with some of the resources, as if somebody wants it, they can get it, and we can go into the social determinants about whether or not they can afford it, or insurance, or anything of that nature. But I think that it becomes an issue of culture, but I think it also becomes an issue of values, and how much value are we placing on an individual life, which I think can vary widely depending on not only one's individual thought, but also the collective thought of that culture.
Yeah, well, this gets really complicated really fast. So let me kind of ground us back in the early days of the pandemic. One of the things we talked about previously on this show was a real concern that at the height of the first wave of the pandemic, we were going to run out of key resources. In particular, people will recall there was concern about running out of ventilators, machines to help desperately ill people breathe if their lungs were severely affected. I don't think we ever got to that point at Northwell. And in fact, I think the reports around the country were that we sort of dodged a bullet there. But can you speak to that particular problem and how your team helped us approach those issues?
So at the very beginning of the pandemic, we were seeing a lot of individuals come in with a lot of severe respiratory symptoms or breathing issues. And initially what we thought, and we quickly, and it's quite remarkable how quickly we learned a lot about COVID in such a short amount of time, found out that there were other organs that were involved upon that. But we were so concerned about the breathing machines, the ventilators, that it sort of became a proxy. Ventilators sort of became a stand-in for all hospital resources. So that included personal protective equipment, that included catheters, that included certain medications used, that included oxygen. And it became more and more of a concern that certain hospitals were going to reach their capacity. And we wanted to avoid at all costs making the devastating decision of having no more ventilators, all of our ventilators in use, and somebody coming into the hospital with a better chance of survival, and then figuring out which person we would have to liberate from the ventilator to give it to this person with a better chance of survival. And so a lot of members of our team and the leadership of our team in the Division of Medical Ethics, we mobilized well over 100 trained individuals in Northwell Health to develop these review teams to try and figure out when somebody comes in and there is a question of whether or not the patient would do well receiving these resources, any critical care resources, including a ventilator, would we go and say this person is not a candidate for said resources, or would we ask the medical team to reevaluate their position on giving this person critical care resources? And it involved trying our best to create an algorithm to do some quick calculations to determine somebody's prognosis or likelihood of survival. And I can say, being on one of these teams and one of the hospitals that was at that point of activating these teams, these decisions were used to try and take it out of the hands of the bedside clinicians so that they didn't have to assume that whole morally challenging responsibility of making those decisions.
And as somebody who was involved in developing those guidelines, this was just an incredibly challenging exercise. Although I think, in fact, and you can correct me if this is not right, I mean, I think we actually never got to that point.
I do think you're right, yes.
Yeah. So let me flip this around a little bit, and we can use the COVID-19 context for this opposite kind of problem. What are the ethical and moral issues surrounding patients demanding therapies that care providers don't believe are medically effective? This got a lot of play in the pandemic for all sorts of crazy therapies out there, very few of which were supported by any kind of clinical evidence. What's the obligation of the care team in that context?
Yeah, well, that is an excellent question. And I think that the pandemic really heightened our sensitivity to this because the evidence was so limited at the time when the pandemic started. And as we started to learn more, we started hearing a lot of anecdotal evidence for these treatments that really did not have any scientific basis of working. So I think the moral duty of the provider when any patient, irrespective of if we're in a crisis mode, they have to utilize, clinical judgment, the guidelines that are available to us with the best known evidence, and help the patient come to a conclusion that the treatment that they are requesting is of what I'm going to say is going to be very blunt, of no value to them. And in fact, may actually cause harm. And I think that was probably the bigger concern, was not only is this not going to affect the COVID-19 disease, but it also was potentially, with a high likelihood, going to cause undue burden. And clinicians are healers. They're not
Right.
they're not there to cause harm.
So ineffective and potentially dangerous.
Absolutely. And I think that, when I talk back to beneficence and non-malfeasance, the balance of risk v. benefit, it's really all about that's an action called proportionality. That is essentially any risk-benefit analysis that we do on a day-to-day basis when we recommend treatment. We just get so heightened in this crisis mode. We get so scared. And I think sometimes that fear that is motivating that demand on behalf of the patient or the patient's caregiver for said non-approved treatment can really overcome them. And so the moral thing and in my view, this is just my view, I cannot really speak for any of my other ethicist colleagues, but in my view, the moral and ethical obligation of the clinician obviously is to try and understand where that demand is coming from using empathy. But I also think it has a lot to do with standing your ground as a clinician and saying, based on what we know, based on what the evidence is, and you have me as your physician, I am not going to give this to you.
Yeah, I think that's a really important point, right? And I'm glad you had both sides of that, meaning the first is to really have a meaningful conversation with the patient or the patient's family if the patient's not capable, to try to not make this a confrontation, to make this a shared decision, but ultimately that doctors and other caregivers are not obligated to do things that they think are wrong.
Absolutely.
Yeah. So I wonder if you could speak to another aspect of medical ethics that has clearly been, I think, highlighted by our collective experience with the pandemic, which is something we touched on a little earlier, which is equity of care, disparities in how different members of our communities are affected by disease and have access to resources. Can you just speak to a little bit of the ethical dimension of how that became apparent during the pandemic?
I think that really brought to light how important it was to really have a strong public health infrastructure, which we didn't have from the get-go. But as we sort of reflect back on what the pandemic has shown, there was a pandemic. In my view, there was a pandemic within a pandemic, and that pandemic within the COVID-19 pandemic was the misinformation part of it. And this really gave light to how people were seeking out information, how we were trying to dispel myths in real time while people were actively suffering. And ultimately, it highlighted a lot of health disparities because there were issues of trust. What news outlet to trust? Are doctors or other care providers trustworthy in this? Are there any individuals or institutions that are having secondary gain as a result of this pandemic? And I think that the inequities that were highlighted had a lot to do with not only what we had seen in history. I had mentioned, the Tuskegee research study, syphilis study. I had also mentioned the Nazi Germany studies. But there are a lot of, I'm sure, more contemporary instances of people who are not being treated equitably and not trying to engage these potential partners in developing policies and strategies to try and build trust early and not just when a crisis starts, when we have to pull everybody together. I think even though, yes, we were at the epicenter of COVID-19 when it came in 2020, I think this could, and I think I'm being optimistic, but I think that this could lend itself to developing strategies of trying to build up public trust early so that these disparities don't don't show up again. And that includes taking a multidisciplinary approach, not just physicians, not just nurses, nurse practitioners, PAs, etc., but also our social services, our social workers, our therapists of all kinds, whether it be mental health or physical health, our spiritual care providers such as our chaplains. I think we have a duty to ourselves as care providers, but I also think we have a duty to our population to try and have these strategies in place for the next pandemic, because it's not a matter of if, it is a matter of when, and hopefully we can address these disparities sooner or prevent them entirely.
And let me just add one aspect to that we kind of touched on earlier, which is the appropriate cultural sensitivity, right? So a lot of these issues of trust and access to care are deeply rooted in not really understanding where people are coming from, which is another way of saying we're not sufficiently sensitive to cultural differences that people bring to their own health decisions.
Yes, I think that we owe it to, again, our population to practice humility in that effect.
Yeah. Well, look, this has been great, and I really appreciate a lot of the insights you've shared with us. Obviously, we have just kind of scratched the surface of a very deep field. I wonder if there are a couple of resources you could point our listeners to if they've gotten interested in some of the things we've been talking about and want to learn more.
One resource that I've actually grown to really like myself, it's actually right on YouTube, and it's a channel called Philosophy Tube. And this specific entertainer, content creator, actually does break down a lot of aspects of philosophy, moral philosophy, in an entertaining way and in a very applied way. So if any of the listeners want to learn more about ethics, they want to learn more about different moral theories, they can always check out Philosophy Tube. And no, I'm not getting paid by them. So it's a wonderful resource.
All right, that sounds great. Sounds like a good place to start. Nicholas Mercado, thank you so much for joining me today.
Thank you so much, Ira. I really appreciate being here.
For more information about this program and to find past episodes, please visit medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.